Thank you all for joining for your lunchtime for the learning management system. The topic for today is acute respiratory failure. What I will do is I'm going to mute all the participants, and if anyone needs to ask a question, they can unmute themselves by pressing *6. Then okay, all right, and then there's always the chat box in case any of the participants wants to ask a question. But thank you so much. Before we start, I thought I'd let the team know that the Aerolib Healthcare Solutions had just launched the idea for the Healthcare Education Innovation Award, and a lot of the topics on this are what are relevant to what we are doing. So auditing, monitoring, billing, reimbursements, compliance, denials, medical necessity. The idea is for the team and pass it on to your colleagues, but have them enter their presentations into this. There's an iPad, Amazon gift cards, and then subscriptions to the learning management system. Easy to get onto aerolib.com and then /award, or if you go onto LMS, the award link comes through. And then there's the upload file, which allows you to either give a PDF or a PowerPoint, a YouTube video, a Prezi video, MP3, whatever you think is would work for the audience. And then this becomes part of the learning management system, where we'll share it with other members of the team. What I'd like to do is start on the presentation. So let's record the slideshow from the beginning, and then it'll be a part of the learning management system. So this is the general disclaimer. I think people on the call who've attended our sessions know that the CPT is not ours. It's a trademark for the American Medical Association. When we refer to Interqual, it's a product of the MCG or the McKesson system. Now, a lot of what we do is part of aerolib.com, and then once you go on, when you scroll down to the Aerolib LMS, these recordings become part of it. There's a login page from the Adobe Captivate Prime, that's our LMS provider. Open up the screen and you see my picture, but you'll see your picture, and then badges and skills maps, and say there's a topic of COPD you want. Click on it. It opens up into the entire course library. Opening up COPD will open up either your PowerPoint or your video, and then you can look at it, or your physicians, providers can look at it at their own time. The beauty is a lot of this is tracked, and so for the case management team, the CFOs, the CMOs can see what sort of education their providers have looked into, how many minutes they spent on it, and the idea is to show them that this is something that would help them with their documentation. The Aorta is our app for the iOS or the Android platform, and as of yesterday, we had about 89,000 views. There's about 160 members, and a lot of the posting happens, and this is free. You can go onto Aorta in either the game store from Android or the iTunes for iOS, and then download it for free. We've already touched based on the education award, and the deadline is the 15th of September, so pass the message on. So how all this started was when we were trying to show that documentation improvement was important. When we had started this, there was so much that was bombarding the healthcare systems. In a lot of these, the first few slides, the reason I use them in all my presentations is that these are important slides. And why are we doing this? Because we're being, we have ICD-10 that came to us last year, CMS 1599 about now almost going to be 3 years in another 2 months. EM audits have always been around. ACOs are an old concept that are now being rebranded in a different format. But the QIOs, the certs, RACs, MACs, ZPICs, OIG, DOJ, they've always been looking at us. HIPAA and high-tech in OCR came many years back, but just recently They are putting a lot of penalties even for minor variations. And then the payers, CMS, insurance companies, they've always been toying around with different auditing formulas. And the need for change is, why this is all happening is they feel that there is variation in the quality of care. They feel there is variation in what is being offered in terms of payments and reimbursement, and they just want to eliminate this unnecessary clinical variation. Hospitals that are joining each other want to make sure that there is less variation in the care that are being provided amongst their own facilities. I think the bottom line is good documentation of good care in a good setting, and if we can always ensure that whatever regulations come in, we'll be on solid footing there. Now, I always bring this slide because who's looking? And so you can see Humana, and Humana is just another example. Aetna, United, everyone is looking at the care provided to their beneficiaries. Medicare itself is looking at it. They released the 16-page Medicare Learning Network article many months back on Medicare fraud and abuse and how to prevent it, detect it, report it. The sad part is the same findings that were released by Medicare were used in the same playbook by the insurance providers. Now, those are not the only ones who are looking. Are malpractice providers. So on the bottom right, you see left of your screen, MedPro Group has been around for many years. It's one of the Berkshire Hathaway malpractice companies, and they've released a lot of claims data as occurrence claim on how to prevent medical malpractice. The American Health Lawyers Association does webinars both on demand and on recorded ones on how to audit physician practices and hospitals and healthcare organizations. The Texas Medical Liability Trust has come out with this 10 things that can get physicians sued, and the idea is not to scare the physicians, it's just to tell them that what they write on the chart is not only good for clinical care, but also protects them from medical legal issues later. And they release this internal medicine closed claim studies. They come out with them every 2 weeks, just beautiful cases. What has changed in the last few months is this is an ad for a hospitalist from one of the big systems in Dallas. And they have made it very clear that compensation is going to be based on not only a base salary, but a productivity incentive and a quality incentive, in addition to HCAPS and citizenship incentive. And when they mean quality incentive, they talk about documentation, improvement, participation in CDIs, making sure the CMUR department queries are answered. So this is a chunk of their money. So this is the first time we've seen them openly advertising that if you don't follow our improvement strategies, there is money at stake. Now, the spectrum of auditors, this has been a common slide, and I always use this to say that, even though we have so many auditors, the bottom two, that is the certs and the QIOs, these are routine compliance. I consider these are our friends. They tell us what we're missing out. The yellow ones, the max, mix, and racks, they are the compliance oversight, and the QIOs have taken over racks position. They're on hold right now, but that doesn't mean they've stopped looking. So they may not be looking at 2 midnights, but anytime a case or a facility gets on their radar screen, whether it's DRG validation, whether it's medical necessity, whether it's post-payment reviews, they are in it. Now, the red ones, the reason they're in red is because these are legal oversight agencies. The ZPICs, OIGs, DOJs, they can, this is trouble if you get letters from them saying, hey, we found this discrepancy in your system. Not to forget insurance companies, now they're sending notice of improper payments and recoupment. This is months or even years after a case has been seen and care has been delivered on whether that care was even necessary or not. And the reason for one of our topics today, acute respiratory failure, stemmed from a lot of these recoupment notices where the auditors felt that the diagnosis was not present in the first place. And that's the reason we're talking about that today. Now, one of the MLN Matters article had shown on how, what they look at in terms of an auditing And if you look at the bottom box in red, it says this clinical judgment review. It involves two steps. So there's synthesis of all submitted medical record information, whether it's progress notes, diagnostic findings, medications, nursing notes, to create a clinical picture of the patient. And then the application of this clinical picture to review the criteria, to the review criteria to determine whether clinical requirements in this policy have been met. And a lot of people have said, when I do peer-to-peer discussions, doesn't meet criteria, and we talk, what criteria are you referring to? And it's either, they mention Interqual or MCG. One thing we need to be clear is, Interqual or MCG has not recreated medicine. A lot of what they use in their criteria is part of medicine itself. In fact, a lot of their tables have been pulled out from Harrison's Internal Medicine, Davison's Internal Medicines, Cecil's Book of Medicine, and then evidence-based criteria. Some actually refer to UpToDate, which again is not recreating or rewriting medicine. It's pretty much compiling all the evidence-based medicine in addition to the text that's already there. So when I look at what their arguments are, that's basic medicine that they're referring to. Now, there's going to be 2 slides on what these agencies are looking at, and I'm not going to read everything, but trying to tell you that they are looking at a lot of stuff, right from when the patient presents to the hospital, what's written, ER, nursing notes, what you're doing on a day-to-day basis, how you're billing, who is billing, whether there's a delay in care, and then they track it back to whether there's good follow-up, and that stems for readmission penalties versus whether the care was delivered appropriately in the first place. So this is a whole gamut of variables they can look at. I think where it comes to us is making sure that when we write, and I've practiced hospital medicine for many years, is making sure the documentation is solid. Now, part of what we do is disease-specific documentation training. And so, today's topic is respiratory failure. We're going to talk about some key points that need to be in a medical record for respiratory failure. Again, this is just a basic formula on what observation and inpatient could be. A lot of you are already familiar with this. Some who are struggling to figure out the 2 midnight rule, they can always reach out to us, and then we can tell them, this is now 2.5 years later. We've kind of figured out what sort of audits will happen and when the audits happen. So acute respiratory failure, a clinical and regulatory review, and people who are on this call and who've been on the LMS know, we talk about some definitions, some pathophysiology, signs, symptoms. We talk about ICD-9, 10 coding, some screening tools, and some coding tips for these disease-specific topics. So definition, again, the next few slides are going to be very clinical, and I think the providers and the case managers would be saying, hey, this is what we've always told needs to be in the chart. So respiratory failure, the acute is the loss of the ability to ventilate adequately or to provide sufficient oxygen to the blood and systemic organs. And the pulmonary system it's just not able to meet the metabolic demands of the body with respect to this oxygenation of the blood or CO2 elimination. So very layman-like language on what the definition is, and then we'll talk about what it actually encompasses. So a PO2 level of less than 60 or a pulse ox of less than 91. And over the next few slides, we'll tell you a lot of times we don't get the ABGs. Sometimes we may not even have the pulse ox, and so how do we make that out? But in addition to that, there is a PCO2 of greater than 50, a pH of less than 7.35, and then this PF ratio less than 300. And I'll talk more about this PF ratio because it's been around for a long time. It's just now being incorporated into definitions, and so physicians need to know how to get this ratio. In patients with chronic failure, there's a PO2 decrease or a PCO2 increase by more than 10. And it's almost always present if there is endotracheal intubation, there's mechanical ventilation, BiPAP, or the need for more than 40% of supplemental oxygen. So that's something that we've won a lot of appeals where patients presenting with either pneumonia or COPD and difficulty breathing had a few hours of BiPAP, and technically in all these criteria, the use of BiPAP does say there is acute respiratory failure. Now there's a couple of types. There's a hypoxic, there's a hypercapnic, or there is a mixed or a combination of two. And I'll show you why it's important in the next few slides. So this is how respiratory failure is used in the ICD-10, and you can see that it's just not simple respiratory failure. There's a whole variations. So the J96 is common, and then the first two decimals, whether it's 00 up or 12 or 21, this is what your coders depend on in your documentation. So just simply saying respiratory failure, pneumonia, that's not cutting the deal. It'll come under unspecified, and anytime you have a higher fraction of unspecified codes, those are red flags and are actually inviting more audits. So again, this is just one slide of what ICD-10 can be for acute respiratory failure. I think for the whole list, the AMA has the entire list. I think online you can find out, but it's important when we go on to the next slide. Why we need to portray the patient's severity of illness. Documentation of this influences quality scores, performance indicators, clinical outcome measures, hospital revenue. If there is pre-existing or coexisting disease with respiratory failure, that needs to be mentioned. So COPD, heart failure, pneumonia, sepsis, post-cardiac arrest, and then chronic respiratory failure. Now, terms that don't help are dyspnea, hypoxia, respiratory insufficiency, or distress. So they tend to go into a box where we don't know what to do. Symptoms are always good when patients tell them, but in terms of billing and after 24 hours, I think we should have a good enough idea on what we are treating and move away from assessment and plan or medical decision making, which has symptoms more than diagnosis or diseases. So hypoxemic respiratory failure, that's where the oxygen saturation is low, or the PO2 is less than 91, the PF ratio is less than 300, or the PO2 decreases by 10 millimeters from baseline, again, if that is known. Now, patients without chronic respiratory failure, those are the ones where PO2 is less than 60, and if you don't have an ABG, then the pulse ox is less than 91. Now, patients with chronic respiratory failure, that's where the definition of a decrease by 10 from a known baseline happens. That's where the physician or the case managers need to dig in and find out, hey, did this patient have a previous admission in the last 1, 2, 3, or 4 months, and what the numbers were at that time. So this PF ratio, the P is actually the arterial PO2 from an ABG, and the F represents a fraction of inspired oxygen, and that's a decimal. So the PF ratio less than 300, it indicates acute respiratory failure. It's been validated, has been used in ARDS and acute lung injury. But let's look at this. So PF ratio less than 300 indicates a mild ARDS. It's equivalent to PO2 of room air of less than 60. If it's less than 250, that's a moderate ARDS. Less than 200 is severe ARDS. So it's basically a relationship between inspired oxygen and arterial oxygen. And a lot of times we may not have that available. We may not have an ABG, but I'll show you in the next few slides how to find that PF ratio. And there's a bunch of websites. The one from Cornell has an online way of calculating that. So in general, if your pulse oximetry is 90%, that correlates to a PO2 of 60. And again, these are all from Harrison's and Davison, so we're not making this up. These are all evidence-based numbers. The question is, how do you estimate the FiO2? Now, people who use Venturi mask know that it can deliver oxygen at a fixed FiO2, whether it's 24, 28, 31, 35. People in the ICU and respiratory therapists pretty much document this in the chart. I know a lot of nurses and case managers also document this. It's one of the criteria for knowing whether a patient needs home oxygen. A non-rebreather mask is actually designed to deliver 100%, and nasal cannulas have adjustable flow rates. And let's look at this. So if a patient's on 1 liter of oxygen per minute via nasal cannula, that actually corresponds to an FiO2 of 24%. And then as you go down the need, 2 liters, 3 liters, or 4 liters, that gives you the estimated FiO2. Nasopharyngeal catheters are the ones where that's an escalation of therapy, and that can give FiO2s from 40 to 60. Face masks, again, between 40 and 60. Face mask with reservoir, and again, I know the case managers, respiratory therapists, the pulmonologists, they will use a mix and match of these, trying to see if we can de-escalate therapy or escalate therapy. But again, that gives you an idea on the need for oxygen and what the estimated FiO2 is. Now, the other type of respiratory failure is the acute hypercapnic one. That's where the CO2 levels are high and the pH is low. So if the CO2 is greater than 50 with a pH less than 7.35, or an increase of 10 millimeters of the PCO2, that's where you have the hypercapnic respiratory failure. Now, this can be in patients, who already have COPD on home oxygen but are presenting with an acute exacerbation. This is the type that we see in the COPD patients. So severe COPD is one of the commonest ones, and then we can establish this by looking at the PCO2, looking at the ABG, looking at the pH. So we can correctly identify it as respiratory acidosis, but unfortunately it's a comorbid condition, in contrast to acute respiratory failure, which is a major comorbid condition. And how does this make a difference? Well, in the next few slides, you are going to see some payment differentials on what happens. So chronic respiratory failure, it's a combination of elevated PCO2, a normal pH, and elevated bicarb, hypoxemia. Things that we look at on a daily basis during hospital rounding. Just needs to be in the chart and then portrayed in a picture that it's chronic. So an elevated bicarb on a BMP is a clue. Now, it's common in patients with severe COPD or oxygen dependent and other diseases, like pulmonary fibrosis or cystic fibrosis. Acute on chronic respiratory failure, that's when a patient experiences an acute exacerbation or a decompensation. And again, why these names are important is in the next few slides, you're going to see some dollar amount figures with associated reimbursements. So a diagnosis can also be made if patient has worsening of symptoms and increased requirement of supplemental oxygen or greater hypoxemia. Now, post-procedural respiratory failure, and this is when you've intubated someone for a short procedure and then extubated them. If the diagnosis is following a surgery is classified as a post-op respiratory failure, it adversely affects the surgeon scores as well as the quality scores for the hospital. So terms like respiratory failure due to surgery or complicating a surgery can have a lot of regulatory and quality of care implications. So patients requiring ventilator support for a short period post-op, that's not a diagnosis of respiratory failure. Mechanical ventilation that was expected or that was usual following the type of surgery, that should not be coded as a respiratory failure unless there is post-op atelectasis, increasing oxygen requirements. But a few hours after extubation, that is expected that the patient will have some difficulty breathing. So diagnosis should clarify if there is, any relation to a pre-existing disease, if there is COPD, CHF, chronic lung disease. Acute respiratory failure in the post-op setting is due to pre-existing COPD or CHF, that needs to be put in. So let's look at one case. We have a 78-year-old female. She's been readmitted through the ER with hypoxemia, hypercarbia. She got her CPAP or BiPAP, but it was applied without oxygen. So she presents with this chief complaint of shortness of breath, and ER says there's respiratory distress, sarcoidosis, there's early CHF. The admitting physician documents the admission diagnosis of a panic attack, hypoxemia, hypercarbia, sleep disordered breathing, renal insufficiency, and chronic anemia. So she has a history of sarcoidosis, chronic anemia, renal insufficiency, but the discharge summary lists the final diagnosis as hypoxemia, dyspnea, anxiety, anemia, and shingles. And the auditor says, well, there is no documentation of acute respiratory failure. Now, unfortunately, in this case, it was mentioned in one of the notes and through billing was submitted as an acute respiratory failure. Again, DRG validation happened, they not only took money back from this case, but they tried to extrapolate it to some other cases as well. So auditor deleted the respiratory failure code and changed it to principal diagnosis of hypoxemia. And so what happened was the DRG changed to other respiratory system diagnosis without an MCC, and there was a huge decrease in payment. So the condition that's chiefly responsible for a patient's admission to the hospital needs to be sequenced as the principal diagnosis, and then the other diagnosis identified should represent the CCs or the MCCs. And these definitely affect the DRG assignments. And, a lot of this needs to be put in whether the condition was present on admission or whether this is a hospital acquired condition. So a lot of us on this call already know what DRGs are. They were made about in the 1970s to describe types of patient care. It assigns a numeric value to a hospital episode of care, and which serves to tell us what sort of payment the hospital should receive. The goal at that time, for CDI in this is to improve documentation to give an accurate and complete reflection of this patient's care, the severity of illness, the risk of mortality. And it's valuable because we need to stick to this quality of care measures to make sure we're giving good care and making sure we don't get into any medical legal liability issues. So shortness of breath is going to be classified to a respiratory sign and symptom DRG. So if the diagnosis lists pneumonia, the patient's acuity is more complex, and that will be a different DRG. Now, listing of other comorbid conditions like renal failure, again, it would reflect the severity and the change and the treatment that is being offered. All right, let's move on to our next slide. So listing of secondary diagnosis and comorbid conditions, it justifies the use of more resources, higher reimbursement. So patient with COPD with a secondary diagnosis of CHF, there's an expected payment of about $8,000. If that same patient has been documented as systolic heart failure, the payment goes up to $10,000 because now there's a comorbid condition. But if there is an acute and chronic systolic heart failure, whether you gave them more fluids or this was a post-blood transfusion, this is a major comorbid condition, and the payment goes up to $11,000. So respiratory failure and pulmonary edema, the moment we start using respiratory failure, the DRG changes to 189, and the payments are $11,695. So now you see why all respiratory failure DRGs are looked more closely, because those are expected to be paid at a higher rate, which is why they start to look back and say, was this a pneumonia? Was this a COPD? Was there respiratory failure or not? Was there documentation of that also or not? So documentation should include in progress notes, whether there's dyspnea following breathing treatments and how many treatments were given, what the oxygen saturation is, what the arterial PO2 is, how this patient has done with outpatient treatment, how this patient has done with current treatment, whether there's mental status changes, what the blood sugar levels are. A lot of the information for payments is available on CMS's website, and a lot of the tables, I think the database has pretty much 80% of all hospitals' payments on what DRG they've billed for. I think they have gone back to till, I think they released it till 2013 or 14 yet, but it's simple to find what sort of payments are going on there. So I'm going to open up it for questions at this time. Okay, are there questions at this time? From the Cumberland team? Okay. 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 Any viewers have any questions? We can go on to some other slides and then open it up for discussion then. Okay. So the reason why all this is important in terms of respiratory failure is it actually determines medical equipment for these patients, and a lot of the these are formed by national coverage guidelines. The CMS has them up. They're updated very frequently. They have one for home oxygen, and I think in our pneumonia presentation we talked about it. But a lot of the focus has been on documentation and readmissions, and CMS released these 30-day mortality measures, readmission measures. One of them, as you can see, is pneumonia. And a lot of the pneumonia is now being looked into, whether this is simple pneumonia, whether there is respiratory failure associated with it or not. And again, the back end reason is there's a lot of money at stake in this. I'm not going to spend time on the definition of pneumonia. We had done this presentation some time back. It's part of the LMS, but we will go through some slides to show what sort of documentation is needed. In all our presentations, we talk about the continued stay. So there's a golden rule. If you see someone today that had an H&P, or yesterday or day before, you need to ask them, why does this patient remain in the hospital today? What's the condition that can only be treated in the acute care facility? And once you've identified that, what am I doing that can only be done? So, patient may have a disease condition, but we know nursing homes and alternate placement settings can deliver IV Resp. You don't need to have every patient with a UTI in the hospital with IV Resp. That can be given as an outpatient in a nursing home setting. Again, oral antibiotics, what's the contraindication to that? Does this patient have intractable nausea and vomiting? The auditor actually looks at nursing notes, I's and O's, and if there is a notation, patient ate 80% of meals, is on the 20 cc's an hour fluids, they have determined that this patient does not need to be in the hospital, at least not for if the DRG build is a UTI. Respiratory CCs and MCCs, and you can see some terminologies on how to use them. Let's go back to the slide. So respiratory distress, acute, ARDS, chronic failure, alkalosis, acidosis, and these are things that help describe the condition of this patient. A lot of missed secondary diagnoses are in, and so I've seen a lot of the physicians now adding BMI. Now, unless this BMI is actually causing obesity hyperventilation syndrome, that's when it becomes significant. But if someone has a BMI of 26 or 28, and from a clinical picture that increased weight is not affecting the current diagnosis, it generally is discarded in terms of when we're looking at whether this is important or not. We've talked about DRGs, the respiratory infections and the use of CCs, MCCs. We've talked about ICD-10 and how specific it has become now. So some of the screening tools, and whether it's Interqual or Milliman, they want pneumonia confirmed by imaging. Some of them ask for oxygen saturations between 89 to 91%, confusion, respiratory rate, and age. And how they came up with this is the CURB score, and that has been around in medical literature for many years. A lot of what the other screening tools also talk about is, whether there's lung abscess, empyema, or necrotizing pneumonia. And by default, by medical knowledge, we know someone with a necrotizing pneumonia, just the fact that the antibiotics, the delivery of the antibiotics, the pathophysiology of what's being treated cannot be done in an outpatient setting. Again, unresponsive or failure of outpatient treatment. Now, this is one where they easily allow hospitalization depending on what you're doing for this patient. So if this patient was seen in the office last week, develops worsening pneumonia, now there's bilateral infiltrates and there's a respiratory failure, that needs to be part of the HPI, that this is not the first episode of pneumonia, it's been going on. A lot of times what we see is failure of an adequate chief complaint and HPI to tell us the story of why this patient's in. Let's move on to some other slides. And again, from a coding standpoint, even for pneumonia, you can see how specific they want it to be, whether it's aspiration, candidal, gram positive, gram negative, whether there's influenza or not. Let's move. I think we've shown this slide in a previous presentation, but you can see some pleural effusion here, very nice cupping and angulation. But there is a straight line here, and I know this is something we use with some of our students, and we told them, how did that fluid line become straight? And I think a lot of people on the call already know it was a patient lying down, and so there is a huge air and fluid pleural effusion that's in this patient. So anytime you see a pleural effusion, there's at least 250 to 300 cc's of fluid in. Now, whether that is significant or not, that's what we need to determine. Whether that's an exudate or a malignant effusion, we need to know. If it's a transudate, what sort of reactive fluid it is. That's the sort of documentation these auditors are looking at. This is a CT of a patient lying down with a huge accumulation of fluid. Parapneumonic effusions, these are usually complicated. There's a high risk of mortality if it has been documented that there is suspicion of parapneumonic effusion, and that is the reason we're on broad spectrum antibiotics, whether it's Vanc, Zosyn, whether it's Teflaro. Those usually get us an inpatient. Again, they do like to see what the LDH is, whether a thoracentesis was needed or not. I do recommend, if there is pleural effusion, document on whether a thoracentesis needs to be done, if it's done, and if it wasn't done, was there some contraindication. That usually helps when there's a peer-to-peer happening. Pneumonias can be hospital acquired, ventilator associated, healthcare associated. Again, these are all definitions, but these are the definitions that actually help payment. So if someone's been in the hospital in the last 3 months, or in a nursing home, hemodialysis, getting chemotherapy, or even in a wound care setting, by definition, spending more than 2 days in the hospital in the last 90 days brings it to a healthcare associated pneumonia. And the Infectious Disease Society of America has released antibiotic guidelines for HCAP versus just a community-acquired pneumonia. Blood cultures, they're traditionally positive only in 15% of the cases, but not saying they shouldn't be done. You just need to make sure who your high-risk patients are. Sputum cultures, urine testing. In this is one of the denial letters from one of the insurance companies, and they have technically used pretty much the same criteria that we have talked about and are part of the CURB 65 evidence-based criteria. So this 86-year-old female, she presents from the nursing home 3 days after a 3-day history of fever, shortness of breath. There's weakness. She's had CHF, EF is 30%, dysphagia, poor gag reflex. She's tachypnic at 24, blood pressure is okay, heart rate's high at 100. She's saturating 88% on 3 liters. There's decreased breath sounds, chest X-ray shows bilateral opacities. BNP isn't too bad, creatinine 1.8 and hemoglobin 8. So the ER says, admit for pneumonia. Now, for this patient, this is a simple pneumonia. If it's just been documented that way, the payment to the hospital is about $3,500. Now, let's say this is a patient, now there was mention of a poor gag reflex, and you dig into the nursing home records and say she's been choking on her foods. It initially started with solids, but now she's choking on some liquids also. So there's a risk for aspiration pneumonia. That becomes a complex pneumonia, and the payment automatically goes up to $5,000. Now we know she has a systolic heart failure. We have that on an ejection fraction. So it's a complex pneumonia with a CC, and the same patient, if it's an appropriate documentation, there's a reimbursement to the hospital of $7,800. Now this patient came in with this EF. ER was very aggressive. They put her on some IV fluids. Turned out the hemoglobin further diluted to 7, and she was given 2 units of packed RBCs. And now she's in heart failure. So this is an acute on chronic systolic heart failure. Day 2, she still has that aspiration pneumonia that you're treating her with. So this is a complex pneumonia and with an MCC, and the payment to the hospital should be $11,000. Problem is, when we have copy pasting of notes, this doesn't follow the progression of how this patient went. So this is a case where she came in for a pneumonia, but the chief complaint is epigastric pain and vomiting. They've done a decent job on the HPI and the exam. and pneumonia, leukocytosis, and they've put in some good documentation on what they're doing, azithromycin, Resp fluids. When we looked at the nursing notes, there's hypotension, there's 95 by 45 blood pressure, and chest X-ray shows some patchy changes, atelectasis. Thing is, she came in with a white count of 19,000. By the 30th, white count is down to 11. The hemoglobin was 16.9. After fluids, it's 14.1. And problem comes in is, there's some discordance. So quality of respirations on a nursing note is using accessory muscles. Now, anytime we know that happens, patient is in some form of distress. Few minutes later, there is no acute distress, patient resting quietly with eyes closed. And again, this is what the auditor looks at. What exactly happened here? And they put in this case is high risk for audit because there is no hemodynamic instability, or because patient is stable and patient is on room air. So one wonders if a patient with pneumonia with good vitals and labs that are normalizing and notation that she's in no acute distress lying quietly, question is, why is she in the hospital? Now, is it not time for her to be, for discharge planning to happen? So what we do in pneumonia cases is we calculate the pneumonia severity index, and then we tell them what risk class this patient is in. We tell them what the curve 65 severity scores are and what the mortality day is for a 30-day. And so when we use the PSI or curve 65, that's not proprietary to us. That is common knowledge that's available everywhere. It's evidence-based medicine. How we lose cases is when physicians start writing 2 weeks to go home. Those are pretty much gone cases. At that point, there is denial of service after this documentation is noted. Or documentation like she is stable currently. So anytime we have something like this, the auditor says, well, that's when we stop care. Now, anything after this is either convenience or delay in care. And the ISTA has released guidelines for pneumonia. The evidence-based medicine is there for curve 65 and the CRB 65 scores. These are the same criteria used by Interqual. I talked about NCDs for home oxygen use, and this is a really good article on, when we are writing DME scripts for home oxygen, on who gets them, when they get them. A lot of our references are through national guidelines and through CMS. And all these are available as click on. They'll take you right to the guideline through the LMS. Again, everyone knows going to Aerolib, go down to the LMS, log in. A lot of people on this call already have logins for it. Open up what you want to see. This presentation will be there by the end of the day today. In addition, you can see the perfect appeal letter, case analysis, condition code 44. That's something that's caused a lot of confusion. 3D mapping of clinical data talks about how CMS actually looks at a case and then picks it up for an audit. Opens up videos and slide decks and a lot of back-end monitoring that can happen for the case management directors. I guess this is it. Any questions from the group?